Hello, welcome everyone. Good afternoon. Gonna give it just a second for any attendees to come in from the lobby, and then we will kick things off. All right, I think we can go ahead and get started today. Thank you for joining us, either good afternoon, good morning from wherever you're at. Welcome to our Outpace CVD data submissions office hours call. I'll start by introducing our panelists for today's session. My name is Liz Montgomery, and I am our Senior Outpatient Programs Consultant at the American Heart Association. And I am joined today in presenting by my wonderful colleague, Allison Smith, who is a consultant for the Heart Association, and in the chat and moderating our Q&A by Anmol Dalwadi, who is a program consultant for our outpatient team. Before we get started, I wanted to review a few housekeeping items. First, please know that this meeting is being recorded and slides will be available after the presentation. We'll email them out for everyone. You can enter questions live into the Q&A feature of Zoom, and please keep an eye on the chat for messages from the Heart Association team. We'll do our best to answer all of the questions that come in during the call, but please know that we will have additional office hours throughout the data submission cycle to answer any and all questions that you have. We also have a contact us form and a help desk here to help with your data submission this year. Our agenda for today's call will begin with an opportunity to identify what topic you have the most questions on, followed by an overview of the data submission process with timelines and resources. We'll pause for an open Q&A, followed by some answers to frequently asked questions that we receive. And throughout that, we just continually, we're here today to answer your questions, so please share them. We really just want to make sure that you have what you need to submit data for award achievement this year. We would love to begin by asking which category you have the most questions on. So we're going to launch a quick poll here and let us know if your questions are more technical data submission questions. Are they maybe more so about the timeline or award categories, or maybe more in the weeds on measure specifications? If they're about our attestation questions, is it about one program or another? And again, like if you do think of any others, hopefully this generates some thoughts and ideas, but drop them in the Q&A and we'll be trying to answer them as quickly as time allows. All right, it looks like we're getting a few in here. Give it just a second before slowing down. All right, looks like we've got questions in just about every category with, if you want to go ahead and share the results, we have a fair number that are technical data submission questions about your user account registration. And then tied in second place is maybe the attestation questions for Target BP and Target Type 2 diabetes. So we will be happy to go through and answer all of those today. We can go ahead and stop sharing. And I'm going to go ahead and move forward. So we're going to start with a refresher on some key data submission reminders. These will hopefully answer some of the questions right off the bat, beginning with our timeline. Right now, our data submission platform is open and you can submit, edit, and revise your 2025 data as soon as you are ready to. The deadline is going to be Friday, May 15th at 11:59 p.m. Eastern Time. Data will be captured at exactly midnight Eastern Time, so that's 1 minute after the deadline, and that determines award status for all sites. Next, our Heart Association staff will be reviewing and validating the data submitted to classify awardees by award level. You may end up hearing from someone on the national or local team during that time if we have any questions about your submission, and your response to those questions may help us to confirm your appropriate award level. During the fall, we'll then notify 2026 awardees with your congratulations email, your promotional toolkit, and celebrate your accomplishments on our program websites. We'd love to continue to celebrate your accomplishments through other regional events, through our national event at scientific sessions, and just anywhere we can. So we always look forward to that time of the year. There are two general steps to submit data for award achievement. The first step is to register if you have not already. This is going to let us create a profile and user login for you in the online data platform. If your organization is new to submitting data, you can go to heart.org/register my outpatient org to register your organization. But if you have submitted data before and you already have a profile in the platform, you don't need to go back through this process. You should already be able to skip straight ahead to entering data, which we'll cover next. On that registration form, we have some basic demographic questions and importantly are going to ask you what programs that you would like to register for. And you can register for all three at the same time. And if you're considering participating in all three, I just encourage you to select them all at the beginning. If you only select one and then later on you decide to add another program, you will need to return and complete the full form again. So submitting the registration form for all three off the bat is going to save you a little bit of time in the long run if you want to continue participating in Outpace CVD and all of our programs. The next step is going to be to submit your data, and you can do that by logging into the data platform. You'll navigate to Program Forms, hit Add New, enter 2025, and that's because you're entering data from the calendar year 2025. You'll just fill in all the fields, check the data entry complete checkbox, and then click Save and Exit. And you can save and return at any point in the time frame as long as it's by May 15th on that deadline. And I know this is a very simplified lens of what the registration process and data submission process is. We're happy to go into the weeds on any of the specific details as they come up, but just kind of wanted to give that overview of the context before we get it started. I did want to pause and just thank everyone for joining this office hours and considering your questions and submitting data early in the cycle. As you can see on this slide, we had over 50% of our 4,600 data submissions in 2025 come during the last week before the deadline. This means that around half of all of our troubleshooting issues and question support did also come within those last 5 business days of the cycle. Our team is here to do the best that we can to help you submit your data in time, no matter when that time is, but we do encourage earlier submission, bringing your questions to us early like today so that we can have a more hands-on capacity to support you. And with that, I'm going to pass it over to Allison to run through some of the basic award criteria that we do get common questions on.
Thanks, Liz, and thanks everyone for being here. So we'll dive in here on the next slide and talk about eligibility and who is eligible to participate in any of the recognition programs for either target type 2 diabetes, check change control cholesterol, or target BP. Any of those or more than one of those programs, we welcome you as a new submitter, a returning submitter, or expanding your submissions to multiple programs. So one of the fundamental eligibility criteria are you an organization, a clinic, an office, a setting that diagnoses and manages patients with that condition. And so you're going to have clinicians diagnosing and prescribing the appropriate lab tests and medications for those patients to be eligible to submit. So if you're just screening and referring, that is some really important work, but not an eligible entity for award consideration. So on the next slide, we'll talk we're just an overview. We're going to talk through each of the 3 programs, both in terms of the demographic details that we ask, the measure specifications, and the clinical practice attestation questions that you will encounter for each of them. So on the next slide, there are some demographic details that transcend all three programs that are consistent across all. And we're going to ask you a question about your total adult population. And for the outpatient visits, so we're going to exclude for medical outpatient visits, so excluding acute care, excluding dental and behavioral visits. So that is sort of the universe of medical visits of adults that we're asking you to describe or quantify. Similarly, among those, we're looking to see the breakdown of the race and ethnicity of the patient population that you are serving based on the HRSA UDS reporting requirements. And we have links to that resource if you just need to verify that. We also ask for a high-level overview of the payer status of your adult patient population, so Medicare, Medicaid, commercial, et cetera. And that helps us understand the complexity of the patient population that you're serving. And then we're also looking to quantify the total number of providers or clinicians that are practicing in the entities for whom you are submitting data. So, and that again transcends all programs. On the next slide, we'll start digging in uh, to the target BP data. And so this is the measure specifications for the core measure that's in target BP, which is CMS MEPS 236 or CMS 165, et cetera. And the denominator for this measure is all of your adult patients 18 to 85 who in 2025, either before or during the first 6 months of 2025, had a diagnosis of essential hypertension and they had a visit during that period, during that year. In the numerator, we're going to want of those patients, those who have their blood pressure controlled to a level of less than 130 over or over less than 140 over 90, excuse me. And so that helps us calculate the percentage of control as defined by this national performance measure. So just to clarify, if a patient was diagnosed in a previous year and had a visit during 2025, they would be included in the denominator. If a patient wasn't diagnosed until October of 2025, that would be in the last 6 months of 2025, they would not be included in the numerator or the denominator. Basically, you didn't have time yet to get their blood pressure under control. So the measure has some sort of cushion built in there, just as an example. And so on the next slide, we'll dig into a little more detail on the attestation questions. I know that's sort of at the top of folks' lists and common questions. There are 5 pillars in Target BP, and within each, there are 6 questions about your practices, thinking about what policies or standards of care you've established, whether you're monitoring your internal performance, and then some specific questions about the substance and the science behind those activities. For those of you who are repeat submitters, there are only a few minor tweaks to those questions from last year, and they're based on the changes that were embedded in the 2025 AHA-ACC high blood pressure guideline. And those are highlighted in yellow here. And as I talk through these just briefly, for those who do have questions, in the measure accurately pillar, we're looking to see if you're using validated and calibrated devices, if you're training and testing your team, if you have a systematic approach to doing confirmatory blood pressure measurements, whether it's in office or out of office with SMBP or ABPM. And then we're looking to see if you're using an infographic, a job aid to remind your care team to measure blood pressure accurately in every place where blood pressure is measured. For the Act Rapidly pillar, we're looking to see if you have a treatment algorithm and if you're using it, and if that algorithm contains a treatment goal of less than 130 over 80. And the nuance here is that it's the asterisks that changed from last year to be consistent with the new guidelines. So it's for all adults with additional considerations for those who are pregnant, require institutional or hospital care, or have limited life expectancy. We're also looking to see if there are prompts to intensify treatment in your algorithm, if there are adherence strategies embedded into your algorithm, such as using single pill combination therapies or synchronizing prescriptions, prescription reminders, things or dose reminders, things of that nature. And then the other element is whether or not there's follow-up within 1 month embedded in your algorithm for patients who are not yet at goal. The Partner with Patients pillar really addresses whether or not you have a policy in place to systematically assess and address lifestyle modifiable risk factors, whether you're looking to see if your team is following that, and whether it includes specific assessment and interventions for nutrition, physical activity, and weight management, as well as for stress. That's the new one in this pillar per the guideline, alcohol and tobacco use. Again, assessing these things and then having some intervention. And that intervention could be in your institution with the education or referral, or to external resources in other institutions with other practitioners or other community resources. For SMBP, we're looking for systematic use of at preparing patients for use of SMPP, seeing if they're adhering to your own policy, and preparing patients for success. Is there training for technique, measurement schedule established with your patient, a plan to relay those readings back, and that you're using SMBP with a critical number of patients, either 30 patients or 10% of your patient population, whichever is larger. And then our equitable health outcomes pillar looks at our systematic assessment of race, ethnicity, and social determinants, training your team to gather that information appropriately, monitoring your adherence to those policies, and then using your control rate data and stratifying it by factors that are relevant to your patient population. It might be zip code or insurance status or a particular subgroup with potentially different needs than the average patient in your population to identify ways, gaps and ways to improve equity. All right, so on the next slide, I think that covers our pillars. We're going to shift gears into check, change, control cholesterol. And this measure for this program, the specifications are for the MIPS 438 statin therapy for the prevention and treatment of cardiovascular disease. In this case, the denominator is the number of patients meeting any of the 4 risk group criteria, which I'll talk about in a second. And the numerator is the total number of patients who are actively using or receiving a prescription for statin therapy at any point during 2025. One thing I'll just sort of a footnote here, with all of these, I really encourage you to read the actual measure specifications, because there are patients who are excluded in these measures. So for example, patients who are pregnant, who are receiving palliative care, things like that. So make sure you're excluding those patients per the specification. On the next slide, we'll talk a little bit about those 4 criteria, and this is for the denominator. So it's a patient who meets any one or more of the criteria described below. So all patients who are previously diagnosed or have an active diagnosis of clinical ASCVD, including a procedure for ASCVD. Patients aged 20 to 75 who at the beginning of the measurement period or whoever had a LDL of greater than or equal to 190, or who were previously diagnosed with or have a current active diagnosis of FH or familial hypercholesterolemia. And then the other option is patients who are 40 to 75 who at the beginning of the measurement period had type 1 or type 2 diabetes. And then the last option is patients 40 to 75 who had a 10-year ASCVD risk score of greater than 20% at the beginning of the performance period. So any one or more of these would qualify the patient to be in the denominator for this measure. On the next slide, we'll move into just some the attestation questions. There's some just a minor update to the first question that if you were a previous submitter, just to call out here. So which of the following describes your organization's use of the ASCVD risk calculators, either using the pooled cohort equation, which was the one that was previously in the previous guideline, or the newer prevent calculator. So, and are you using it as part of a standard process? And then there are some select all that apply options. There are no changes to the other 2 questions regarding your use of a treatment plan for high-risk patients or your familiarity with the prevent calculator. Your answer may have changed from last year because your organization may be more familiar with it than previous years. All right, switching gears to target type 2 diabetes. This program uses CMS MIPS 1 for its performance measure, the diabetes glycemic status assessment for greater than 9%. So in the denominator for this measure, it's patients 18 to 75 with diabetes with a visit during 2025 in this case. And the numerator is the total number of patients whose most recent glycemic assessment, either by A1C or GMI, that was performed during the measurement period of 2025, is greater than 9% or was missing, or it wasn't, performed during that measurement period. So this is a measure where, sort of lower is better as opposed to the other performance measures where higher is better. Um, and you're also going to be submitting either the MIPS 236 or 438 along this one. So along with this one. So on the next slide, it sort of spells out in a little more detail that in addition to reporting the diabetes measure we just talked about, you're also you have to choose one or the other or both of reporting MIPS 438 that we just talked about or MIPS 236 that we just talked about. And if you're going to do that, I hope you're applying to the other programs as well, because you have more opportunities to recognize your team for their great work. All right, on the next slide, I just want to highlight the attestation questions that are new in 2026 for target type 2 diabetes. And there was just to call out here, because I won't go into great depth, but there was a webinar in July of 2025 announcing these questions. And there's a QR code in the corner here, and this is also available on the website to go and watch a deeper dive into these new questions with a little deeper sense of the rationale behind them and the intent of them. But at a high level, these pillars mirror the pillars to a certain extent that you've seen and may be familiar with in Target BP. So looking at assessment, treatment, lifestyle modification, and equitable health outcomes. And so for assessment, we're looking for a standard, establishing a standard of care and monitoring to see if you're using it. So that should sound familiar. Looking to see the degree to which your organization is assessing glycemic control at least 2 times per year, assessing lab values of kidney and renal function, and using the KDIGO heat map, and then thinking about assessment and evaluation of comorbidities and the use of team-based care models to support patients in their care. For treatment, we're looking at, again, some parallels that should sound familiar here. Use of an algorithm, monitoring to see if you're using that algorithm, specifying a treatment goal for their A1C of less than 7%, as clinically indicated, of course, and then prioritizing the use of SGLT2 and GLP-1s, as well as specifying a treatment goal for LDL less than 70. And specifying a treatment goal for blood pressure less than 130/80. So we know many, patients have high risk and comorbid conditions. So thinking about cholesterol, diabetes, and blood pressure in an integrated way in that treatment algorithm. For lifestyle modification, again, what is the standard of care? How are we systematically assessing every patient for their needs and intervening accordingly? Monitoring use of that algorithm or that treatment standard of care, and using providing access to DSMES or similar, providing access to counseling and weight management, discussing ASCVD risk, and intervening accordingly on modifiable lifestyle resources. Again, within your organization or referring to community or other institutions' resources. It doesn't have to all happen under the same roof, but so long as you're thinking about identifying those needs and trying to meet them. And then in terms of equitable health outcomes, this is quite similar, adopting a policy in race, ethnicity, and social determinant data collection, monitoring your use of that, supporting your team in the techniques to gather that data appropriately, and using that data to stratify your control rates and your performance rates by the factors that are relevant to your patient population, and then taking some action to address those gaps. So with that, I think it's time to turn it over to Liz to talk a little bit more details about resources.
Thank you so much, Allison. And we will start to answer your questions very soon. But before doing so, I want to do a quick run through of the resources available to support your data submission. This way, if we're referring back to a specific resource while we answer your question, you have a foundation for what we're speaking about. And this library of resources has really evolved over time to provide support on the very questions that we are asked by organizations. So your participation and feedback today will certainly help us to continue to improve these resources in the future. First, I wanted to highlight our Outpace CVD data platform website. The URL for this is at the top of the slide and is going to be dropped in the chat. But consider this your home base for the steps to gain access to the platform, to find navigating tools, and to access all of our foundational resources for each of the three programs. Things like the FAQs, data collection worksheets, etc., that I'm going to walk through in the upcoming slides. So we've brought those all together in one place, and that is this website. If you are an organization who is registering and submitting data for the first time, there is a PDF and a video that will help you get set up and familiarize you with the platform. These will guide you in things like choosing the site characteristics that accurately reflect your organization, which will provide greater depth to the quality improvement benchmarking reports and tools available to you in the platform. If you are a visual learner who would prefer a more step-by-step tutorial on how to submit data, then we have two resources I would direct you to. One is a PDF guide and one is a video demo. You can start and stop at your own pace and see exactly what goes into submitting data, along with some tips for ensuring you don't run into issues if you have two conflicting answers, that might stop you from saving your form. And this will show that to you in real time what that looks like. So if you're here for, that deep dive of like, what does data submission look like? These are where I would direct you to. Next, I want to highlight our data collection worksheets. These go into the greatest detail on the questions that are in the platform so that you can reflect on them in preparation to submit data. Since our questions really do span, as Allison just walked through, from measure specifications to different clinical practices, many organizations like to print out these worksheets and use them to be able to collect information from their different team members who might have an answer to one question here, an answer to another question here. These are also a great way to reflect on where your organization was performing in 2025 last year so that you can take action in 2026 to see greater performance next year. For other questions that routinely come up, we do have FAQ documents that dive into the data submission mechanics, the measures and their specifications, and the award criteria and levels. Beyond the FAQs themselves, we wanted to provide a more substantial resource for answering our evidence-based activities questions in our Target BP and Target Type 2 diabetes programs. Our resources and examples toolkits go into great detail and provide examples on how to achieve the intent of the individual attestations. So you can clearly see what would constitute a yes answer or what might constitute a no answer. Within this document, we shared the guidelines from which these attestations were developed so that you can understand why we are prioritizing them in our programs. And these resources can also help you identify where you might be able to strengthen your practices moving forward and additional resources to help you achieve those goals. Last, I wanted to highlight that we do have an increasing number of organizations who are choosing to submit data for many individual locations rather than just as one single health system site. If you have 5 or more locations that you are submitting data for, our multi-site data uploader tool can be a real time saver. So instead of manually submitting your data site by site in the program forms, which is you can instead populate a CSV file and then upload it in the platform. If you are still only submitting data for a couple of sites, then it's still going to be easiest to go through the program form. And that is the method that is highlighted in the previous data tutorials I just featured. But if you have more like 10, 20, 200 sites, then you'll find that this uploader tool can save you a lot of time so you don't have to do all of that manual work. But because of the nuances involved in populating the template spreadsheets, we offer one-on-one support for this option at the local level. You can reach out to your local Heart Association staff member for detailed instructions and support on this tool. If you are not yet in contact with a local staff member, then please use our Contact Us form to get connected. We would love to connect you with someone who can help guide you through this process, and they are also just great sources of information beyond our programs as well. With that, I think we can go ahead and jump into the Q&A. If you're still thinking what you might have questions about, I've got a couple of themes up here, and we can start with what is in the queue. Amal, do you want to highlight some of the questions that have come in?
Yeah, we've had two questions which Allison has shared an answer to, but Allison, maybe we can share with a larger group.
Sure.
Can remote patient monitoring be used to fulfill the SMBP pillar?
Yeah, that's a great question. And really, we try to write all of the attestation questions agnostic to whatever technology or systems that you do have. And so SMBP can be performed, you can meet the attestation questions with, devices and paper, if that's part of your how you can prepare patients in the office to, measure accurately and establish a measurement cadence and fulfill all of those other pillar criteria, and have them bring that data back on a piece of paper. You can also have more elegant systems like RPM systems where it's integrated either into an external platform or all the way into your EHR. But it's really the criteria really focused on the clinical activities of preparing a patient for success, measuring at a cadence that gives you a sample of data, and then using that data to inform diagnosis and treatment decisions. So great question. And yeah, we want to write the criteria sort of for all comers and all technical environments. So thank you for that.
And Liz, I think this will be a great question for you. If you're new to Target BP and have not implemented within the clinic, do we still complete data submission?
Yes, that's a great question. And absolutely, we welcome anyone to start their journey with Target BP and or other programs wherever you are currently at. So the data submission process will ask you, as we just walked through, information about your 2025 practices, and that will give you a great baseline to then be able to implement different resources and activities that are embedded throughout our programs utilizing our quality improvement tools. And then in future years, you'll be able to compare your performance this year, not only with the measure specifications and hopefully seeing better and better performance that way, but also being able to keep track of your attestation activities as well. So being able to see this is where we were at in our systematic practices for these different evidence-based activities, and then this is what we worked on in 2026 and then in 2027, so that you can have, we're really looking at the journey of quality improvement and assisting you along that journey and knowing that that's going to look a little bit different for every organization. But yes, absolutely, welcome your data submission this year.
I'll just add that one of the common questions we get for first-time submitters, if folks haven't had the opportunity to prioritize and strengthen their performance yet, some folks say, "Oh, I don't want to submit until, I'm perfect." And I think to Liz's point, it's a journey, and that's what we're here for. You have the option of not having your award status shared publicly. Like that's a choice that is down the road once we review the data submission. So if that's, we certainly understand some organizations may want to wait to make that information public down the road, but you might as well, to Liz's point, take advantage of that assessment process and charting your course for what's the next priority in terms of improvement. So thanks.
Thank you, Liz and Allison. We have another question, Allison. This may be a better fit for you. With the rebranding of blood pressure cuffs by multiple chain retail organizations, how can we verify certification process if we don't know the manufacturer?
Oh, so I think this is a great example of some RPM companies or other retailers. They call it the sort of white labeling. Usually, you can dig into the package inserts to figure out who the actual device manufacturer is, and then verify whether that's on the validated device listing or not. I mean, there are literally 500 or more devices on the market. So I can't, if you want to send a question to us about a specific device, we can dig into that. But usually the package insert will give you those details. And if it's not, because we do have some of those manufacturers on the validated device listing as well as the ones that are branded per se. So yeah, that's a tricky question. And really, again, that attestation question is asking, is it validated or not? It's asking if you're checking to see if your devices are validated. It's not a requirement to have validated devices. So there's a nuance in that question there. Any others?
Yeah.
We did not, I'm just going to go ahead and jump in here. We did get a question to clarify the data submission time frame and asking about October to December 24th and January to September 2025. So I think this might be I answered in the Q&A, but I think this might be something that we can delve a little different because I'm wondering if this might be a measure specific question too, with some of the nuances for the controlling high blood pressure measure. But to answer the first question, the data submission timeframe is going to be open until May 15th at 11:59 p.m. Eastern Time. And it always opens at the beginning of the calendar year. And this is because our measure specifications are always going to be looking at, as well as our attestation questions. We're going to be looking at the full 2025 calendar year. So we want to see what happened in your organization from January 1st to December 31st of 2025. And that's what you'll be submitting your data on in the platform. So we can't open the platform until that year is concluded because it needs to go, up to the end. But I think that there might be a question here, and Allison, I'll jump back to you, but
Sure.
the dates sound similar to what we were talking about in our denominator here.
Yeah. So each measure specification for each program, it's confined to the year of 2025 to Liz's point. But the way the high blood pressure measure works is that it looks at all of your patients who either before 2025 or in the first 6 months of 2025 had a diagnosis, a new diagnosis or an existing diagnosis of essential hypertension. So it happened, we needed to know they had hypertension by at least halfway through the year, to consider if they should be in the numerator, and that's was their blood pressure controlled, to a point of less than 130, 140 over 90, during that, on the last blood pressure, of that year. So what's tricky is if a patient wasn't diagnosed until October, they shouldn't be included in the numerator or the denominator. But if a patient, was diagnosed before 2025, they would count in the denominator for sure. And if their blood pressure was controlled, they would count in the numerator. And then another example would be if a patient was first diagnosed, in March of 2025, they would definitely be in the denominator, and if their blood pressure was controlled, they would be in the numerator. So hopefully that helps. If there's
There's
more to your question that we didn't cover, please ask again or fine tune that. Thank you.
looks like we have a follow-up question here on, do you remove those from the numerator? Um, and then will the date frame be from January to December 2025? Or so if they're from January to December 2025, do you remove them from the numerator? I'm guessing that's the diagnosis taking place between, um,
Yeah, I'm not, if you have thoughts here, Liz, I'm not quite tracking.
I think again, it's that first, is that first portion, like the diagnosis has to be again, the first 6 months of
Yeah.
the calendar year. But if you do want to delve into more detail on this topic and like go back and forth a little bit on it, I would recommend reaching out through our contact us form or to your local representative, and we'd be happy to go into the weeds a little bit more on some of the nuances. So always recommend
Yeah.
that just to make sure that we're addressing your question correctly.
Yeah, I'll just say that if a patient had their first diagnosis in October of 2025, and their first visit, they wouldn't be included in the numerator or the denominator. So maybe that's the um,
Okay,
question. So,
I think we're good.
okay.
I think we're good.
Yeah, because you,
Um,
you think about like you didn't have a chance to control their blood pressure because it was so late in the year, so the measure has some sort of forgiveness and real, kind of reality built into it.
yeah, absolutely. All right. Thanks for some great questions. I think that we've caught up with the Q&A. So I'm going to go ahead and navigate back to where we were before. And moving forward, I'm going to, Allison and I have some common questions that tend to come up year to year or during previous office hours. But if we get additional questions in the Q&A, we're happy to pause this segment to go to your live questions. So please keep them coming. And here are some common scenarios. So I wanted to start with some of the technical questions that I do see pretty frequently, and I know a lot of our responses to the polls were around these like technical logistics. So one thing that comes up pretty frequently is like organizations branding name changes, right? So maybe your name in the platform is a little bit different than how you would like your name to be listed for an award. And you can always reach out to us at our Contact Us form, and we would be happy to ensure that the correct name is reflected both in the platform and for your award. And again, your local staff can help with, I'm just going to keep calling them out because they can help with every step of this process. However, if you have undergone a merger or another legal change, we may need you to re-register. And this is because, your registration represents that program agreement form. And so if your organization has legally changed, we may need you to re-register as the new legal entity. Next, we do continue to get questions on adding additional programs if you've been submitting for one of our programs for a while. So we have most frequently organizations start with Target BP and then they want to add cholesterol or diabetes programs to their existing profile. And you can absolutely always do this. And you can do that by, again, going to heart.org/register my outpatient org. And you can acknowledge in the first part that you're already, our first question asks what programs you're already participating in. So you can say Target BP. And then the second question will ask, what would you like to add? And it'll prompt you to choose whichever remaining programs are available and go through that process and then sign the agreement and we'll sign you up. But if you have questions, please let us know. The next question is really around what do you do if you can't log into the platform? And if you are a brand new user or you're replacing a staff member who submitted data previously, you can reach out to our contact us form again. We typically just need your organization details, your address, phone number, and we can get you a new user account set up in the platform with access to your organizational profiles. And I will mention that you can have multiple users at one organization. So you may have a couple of analysts, or you may have somebody who is looking at the clinical attestation practices and another person who's working on the measure specifications. And so you can both have access to your organizational profile with your own individual user accounts. There's no max on this, so we do find that sometimes it helps with staff turnover to have a couple of people with current access to the platform. If you have been in the platform before and you have an existing user account, you can try the password reset option, or you can contact our IT vendor at Infosario Outcome Support at quintiles.com or the contact us link. We try and make all options available for resetting your account. And I will mention that accounts become inactive if you haven't been in the platform for a while. So if you submitted data last year in 2025 and maybe you logged in a couple of other times throughout the year, you may have gotten a password reset as part of the beginning of the data submission process. We do one large user reset and email everyone in advance. So you may have gotten a temporary password that way. But if the timing just didn't line up, you may need to request a password reset. And I also wanted to call out on this slide that if your organization has just registered for a new program or registered for the first time, you may take up to like 3 business days to see that processed. It is a manual process to set up the accounts, so this does depend on our team, and we try to process them as quickly as possible. But it isn't automatic, so it will take a little bit of time for us to get in there, make sure everything is set up correctly for you. All right. Oh, and then I do have a question on here. We do get some questions on how to divide patients by their primary payer, and there is guidance on each of the data collection worksheets. The final page goes into great detail on those categories. And let's see. So this is a question on if your health system includes dentistry, behavioral health, inpatient, like if you have acute care visits, do you include these encounters in the total patient population or the measure denominator? And I did want to just highlight this. Allison spoke about it a little bit earlier on with our eligibility and our demographic questions. But our awards and in our programs are really focused on the care that is being provided in the outpatient setting by providers who are actively diagnosing and treating hypertension or high cholesterol, diabetes, depending on the program itself. But because of this, we want those answers to represent where this care is taking place so that we can accurately see, see your control rate in the proper context. So for that reason, we do ask that you filter your data to exclude those acute care visits, dental, mental health care encounters, etc. There are some nuances to this, so we always defer to your definition. So one example of this is like women's health, OBGYN clinics. Sometimes we do know that women are seeing their providers in these settings and getting their blood pressure managed, but not all the time. And that's so highly dependent on what your organization is doing and how patients are participating with their care team there. So there is a little bit of nuance that we leave up to the individual organization, but as a general rule, we do exclude, outside of where hypertension is being treated and managed. And with that, the next category of questions, I just wanted to pause, make sure we haven't gotten any more in the Q&A. Okay. All right, Allison, you want to answer some common target BP questions?
Sure. Here's some of the common questions that we get that are more clinical in nature about the pillars. And one is about sort of the question that asks about monitoring. Are you monitoring your use of a policy, and what are the requirements around that? Is it a chart review? Is it need to be an automated approach? Or is there even a threshold of adherence to our own policy that we need to meet? And really, the intent of this standard is like, are you looking to see, sort of a standard on a shelf that isn't followed, doesn't change, doesn't move the needle? And so the spirit of this is, are you looking to see if your team is actually following the standard of care that you've met? And there are always patient exceptions, so we're not asking you to report or achieve a certain level of compliance or adherence to your standard of care. And we're again, agnostic on the elegance of the solution to do that work. So whether it's a manual chart review, like a sampling method, or whether it's using an EHR, a population health tool to do that, that you're certainly, we're open to any of those solutions. Every organization's approach is a little bit different. So you got a lot of latitude and how you can adhere, and attest yes to this question. All right, on the next page, what we all often get questions about, wait, is it 140 or 130 or 180 or 190? Like people are sort of, where are these different numbers coming from? And so there's a difference, and sort of the three columns here represent three distinct ways to think about it. There are diagnostic thresholds, and that is, if we look at the 2025 AHA-ACC high blood pressure guideline, there is sort of the familiar rainbow chart. What are the thresholds? What's normal, what's elevated, what's stage 1, what's stage 2, and what are those cutoffs? So there are a variety of diagnostic thresholds that are defined in the guideline. Also defined in the guideline is the recommended treatment goal, which for all patients is less than 130 over 80, with the intent to get to less than 120, the encouragement to get to less than 120 over 80, and that is a treatment goal, driven by the guideline. The performance measure, and the thing that you see in the specifications for MIPS 236 that we're asking you to report as your control rate, is something that is defined by NCQA, and they still use less than 140 over 90 in their definition of the performance measure. So again, sort of there three different sort of terms maybe that you'll run across, and sometimes the numbers vary. Our hope is that they will be synchronized in the future, and we really encourage organizations, if your EHR has the capability, to look at your control rate using less than 130 over 80, because that has more clinical meaning and more risk reduction. Organizations who have control rates at 70 might look at their control rates using the cut point at 130 over 80, and their control rate may drop into the 20%. So there's really there's a great opportunity here to dig deeper, but that's sort of beyond the scope of the award criteria at this point. So with that, moving on to our next well, this is sort of reinforcing that key point, that 140 over 90 is what NCQA uses in the performance measure that you're reporting for your control rate, and less than 130 over 80 is what is recommended as a treatment goal for patients. And that also appears in the attestation question for that pillar, the A pillar, the Act Rapidly pillar, asking if your treatment algorithm specifies that treatment goal of less than 130 over 80. So hopefully that clears that up. I think there's one more question. So moving on to a commonly asked question for target type 2 diabetes. What counts as a standard of care? And really the intent here is that you've formally defined and adopted something that you can systematically and routinely use in your organization and is recognized. It may be called something different. It may appear on paper. It may be embedded in an electronic format, but really it's the recommendation is to define and use a standard of care that's recognized across the organization. And then the other question is, can one policy or standard of care sort of cover all the standard of care questions for a pillar. It's really up to you whether you break those down into separate pieces or you bundle them all into one. Every organization approaches this differently. So again, there's latitude here, but the intent is that you've consciously sort of put pen to paper and said, what is our standard of care? And how do we formally adopt it and systematically implement it? Okay, and then the next question for target type 2 is about the treatment pillar. So one question we've gotten before is prescribers and organization want to prescribe SGLT2s or GLP-1s per the guideline, but often they run into the barrier of cost, and it's either not a patient doesn't have insurance or it's not covered by a particular plan. Does this, is this a disqualifier? Can I not say yes to question 17? And the answer is that it's really about the intent. Does your algorithm prioritize and prompt the use of those medications when it's appropriate for that patient and when it's realistic and possible? It's about making that part of your standard of care. If there are realities that where patients aren't appropriate or it's not accessible, that does not disqualify you from saying yes. So it's about whether or not it's in your treatment algorithm. All right. So when
Allison,
we yeah.
before we move on to the next question, I
Yeah.
did just want to flag while we're on this topic that Target Type 2 Diabetes is going to have a professional education webinar on the practical considerations for the use of GLP-1 medications. We're targeting this June. So I just wanted to encourage anyone who is interested in learning more about this or about the barriers that your organization is facing and potential solutions for that to sign up for our newsletter to receive information about this event as it becomes available. We will, of course, be sharing with our Target Type 2 Diabetes participants, but did just want to flag it since this is a question that keeps coming up for us. So thanks for letting
Great.
me jump
Oh,
in.
sure. Please. Thank you. All right, and I think we have another question. So, for this has to do with the pillar question about diabetes self-management and education and support programs. So, if your organization doesn't provide that or obesity counseling, for example, sort of under the same roof or in the same clinic, but you refer, that's just fine. You can say you don't have to have all of the answers under your roof. The idea is that you're referring patients either internally or to community-based or other organizations to have that sort of that care available and making that referral. And then similarly for obesity counseling, if your organization offers obesity counseling to everybody who's eligible, but a patient declines, sort of would all patients need to complete the counseling in order for my organization to attest? Yes. No, really, again, it's systematically assessing and offering or referring. And if it's not appropriate for the patient, or if the patient declines, or if there are other practical barriers to that care being delivered, we certainly, it's about the systematic implementation and offering of that standard of care, that guideline directed care. So hopefully that helps. All right, and then I think we have one question here about target type 2 diabetes. So if will my measure if I'm entering my data for target type 2 diabetes, will my measure data automatically be entered in the target BP and the check change control cholesterol platforms because if I'm entering those measure specifications for the required additional measure? So no, at this point you actually have to go into each of those programs if you want to be considered for multiple awards across those programs. So you have to go in and re-enter. It would be the same. There's consistency across the programs, but you have to sort of re-enter that for target BP and check change control cholesterol. So I don't know if you have any other nuances you want to add there, Liz, because you're the sort of wizard at at this.
No, we're always looking for ways to make the process of data submission a little bit easier, but there are certain limitations with the system. So thanks for your patience as you submit some of the same information across programs, but we do evaluate and look at that data individually and across the programs once it is submitted. So Thank you for walking through that, Allison.
Yeah, certainly worth the effort though,
Yeah.
your teams, we hear it all the time, how valuable it is for teams to see their work recognized. So thank you for making the effort to celebrate their work.
And we are just wrapping up the hour, so going to run through and just thank you all for attending today's data submission office hours. As a reminder, we recommend that you are in touch with your local Heart Association staff member for resources, data submission help, and improvement support. And our national team would be happy to connect you with that team member. You can always get in touch at our Contact Us form. And just thank you again for prioritizing the patient care in your outpatient setting and participating in our Outpace CVD programs. We look forward to celebrating with you this fall with your achievement awards. Take care.